So as much as I get very excited about new technologies and applications, want to circle back really on thinking about ways in which we can potentially again kind of bridge that gap. And so looking at specific settings where there's established clinical utility for these liquid biopsy approaches, wanted to talk a little bit about and highlight the Labcorp plasma focus assay, which is a targetable, highly actionable, guideline-driven, centralized testing solution. And so for those that aren't familiar with this approach, it's a 33-gene panel really focused specifically on biomarker alterations that are associated with FDA-approved and guideline alterations, with a focus on achieving fast results. Turnaround times typically about 7 days. In tumor types where there are often multiple different genomic biomarkers of interest, that more comprehensive profiling solutions, than single gene-based approaches could help to stratify. So looking primarily at non-small cell lung cancer, colorectal, breast, gastric, esophageal tumors, and melanoma. So a little bit more detail. So again, it's a 33-gene, clinically oriented panel focusing on a combination of single nucleotide variants, 8 genes for amplification analyses, and 5 genes for translocation analyses. Really covering all of the FDA-approved and guideline alterations for these different indications I just highlighted. We also report microsatellite instability status, given the pan-tumor association of microsatellite instability with response to immune checkpoint blockade, and then in support of potential future standard of care options, provide a geocoded clinical trial data set to be considered for patient management as well. So gene list is highlighted here. Really, and maybe the main thing I'll highlight here is just that we do evaluate the full coding sequence of all of these genes for SNV and indel analyses, and then again, I focused the specific genes for translocation and amplification analyses on those that are associated with clinical actionability. So one question we get asked a lot, and I think as the field is still working to optimize is who's going to benefit from liquid biopsy-based assessments, and when should it be used? So certainly not advocating liquid biopsy as a replacement for tissue-based profiling, really complementary. And so highlighted a couple of bullets here for where we've seen the most most value for liquid biopsy-based approaches. Through some of our data, which could be patients with an inaccessible tumor to biopsy, those with poor performance status or where a tumor biopsy may not be appropriate, could be unavailable due to insufficient specimen, just may have been exhausted through prior testing, or the patient is particularly in later stage disease where disease progression or recurrence has occurred. Rapid results may be needed or biopsy may not be an option. So really the prototypical example of this, being non-small cell lung cancer with a broad variety of different actionable driver oncogenic alterations, across a range of sequence changes, structural alterations, that now have been demonstrated to improve patient outcomes, through a number of different therapeutic modalities, and the comprehensive assessment of these different alterations, ultimately identifying the right therapy for the patient based on their underlying biomarker profile. So in terms of reporting, I think anybody that's has put these together, really recognizes both the challenges and opportunity for trying to do this in a robust way. So just kind of walking through our report. This is a representative lung cancer patient, where we summarize FDA-approved and investigational treatments that are considered based on the patient's disease state and biomarker status. Digging into a bit more of the front page, focusing initially, right at the top, variants and genomic signatures of strong clinical significance, where we also highlight FDA-approved therapies within and across indications, with a summary of clinical trials up front, before going into variants of potential clinical significance and biological significance. And then subsequent pages, outline, guidelines in this specific setting, and then additional information about the FDA-approved therapies that have been identified within and across indications, and summary of geocoded clinical trials that the patient may be eligible for. So one of the things that we thought may be helpful, and wanted to kind of walk through and kind of from an experience standpoint, and from some of the data that we've seen through initial early access testing of our Labcorp plasma focus assay, is a Q&A session with Dr. Khasawneh, who's going to be joining us and sharing his experiences with the liquid biopsy portfolio. For a little bit of background, Dr. Khasawneh is a hematologist and oncologist at the Pikeville Medical Leonard Lawson Cancer Center, and has seen a variety of different cancer types through this initial period, ranging across lung cancer, colorectal cancer, breast cancer, and esophageal cancer, with about 31% of cases achieving a clinically actionable or relevant mutation identified, with about half of those being tier 1 variants that are highlighted here, and an average turnaround time across this initial cohort of 6.5 days. Yeah, so thanks for joining us. I think one of the things that we wanted to get your perspectives on in thinking about how to integrate liquid biopsy-based testing into your practice, has been maybe starting at a high level, but just thinking about the different types of cancers you treat and the types of patients you see within your practice.
So we were kind of in the early access program for PGDx. We used it in many patients. So PGDx is approved in 7 tumor types, mostly upper GI, colon cancer, lung, breast, and it's very easy. There is a kit that's available for our lab personnel to collect the data specimen in. You get an email with the results.
How do you think about next generation sequencing kind of more broadly within your practice? When you're making the decision as to patient has a specific tumor type, and then the diagnostic workup for should we proceed with a tumor tissue based assessment or liquid biopsy, and how best to kind of manage the diagnostic.
Awesome. So in my practice, actually, if the patient fits the 7 cancer types of PGDx, I actually send both tissue, NGS, and liquid biopsy. Okay. But the liquid biopsy results obviously will come back sooner, so I can act on it much faster, awaiting the final NGS. And in my clinical experience, I have seen almost 100% concordance between the PGDx liquid biopsy and the tissue NGS results. So there was no surprises on the results.
Okay, great. And then, in terms of, I think you talked a little bit about some of your experience with, tumor tissue-based approaches. And so, how do you, it sounds like you're sending both sample types kind of together in parallel, and then, managing, based on the results provided. Are there any, specific settings, and maybe it's too early to kind of see, where, you may get a liquid biopsy result back, and you would wait for the tumor tissue-based assessment, to further inform how to manage if it's, if there's limited findings or that type of setting?
So yeah, in those situations, I typically, if the PGDx results are positive for an actionable mutation, I act on it. I prescribe that treatment that I think is right for the patient. But as I mentioned, Mark, there is always, my experience has been always consistent between tissue and liquid biopsy. On a side note, actually, some patients, I have a patient who's 86-year-old, and he said, I don't want to get biopsy of the lung lesion. He had prior pneumothorax from biopsy, and PGDx was able to identify a mutation that I would never been able to get because the patient refused the biopsy. And in clinical practice, sometimes the location of the target lesion is very close to a vital organ like the aorta or the airway, making a biopsy really having high morbidity to do a biopsy. So the patients or the physicians decide to just go with liquid biopsy.
Okay. Yeah, thank you. And then, it sounds like from there's the turnaround time component to tumor tissue-based assessments. Do you see, other challenges that may be associated with tumor tissue-based, testing and where liquid biopsy could complement? Do you see settings where, you send in a sample, but, maybe there's a high QNS rate, or, high failure rates, or where the liquid biopsy solutions as well could support?
Yep. That's an issue actually I encounter a lot, especially nowadays. We do mostly fine needle aspiration. And in the community, sometimes the pathologists run a lot of immunohistochemical stains, so that exhausts the specimen, making NGS kind of impossible to run on the remaining tissue. If you have a small sample and then you exhaust it in making the diagnosis, you don't have any tumor or tumor tissue left for NGS testing. That's an issue. The second one is that sometimes if the patient initial diagnosis is 4 or 5 years ago, and now they're having metastatic disease, the genetic makeup of the metastatic disease can be different from the primary. So you might run the NGS on the primary specimen, but the metastatic lesion can have a totally different clone or genetic makeup. So I always try to do a tissue at the time of recurrence or metastases, but if that's not possible for any reason like patient refusal, location of target lesion, definitely liquid biopsy has been so helpful for me.
Yeah, thanks. Yeah, I think if you probably, maybe at prior ACRs before the pandemic, had asked a broad range of people, is liquid biopsy going to replace tissue? I think we found, based on what you've just described, really a number of scenarios where, liquid biopsy can actually complement, tumor tissue-based testing, and that's really, where, ultimately the patient's benefiting, from that combined approach. So, it sounds, in terms of identifying patients that are going to be the most, suitable for a liquid biopsy-based assessment, are you triaging patients, that would receive a liquid biopsy test, or is it really kind of, any patients that kind of fall within this, set of tumor types that are appropriate?
I honestly run it on some patients without knowing the primary, just being part of the early access program. We found actually like FGFR alteration in a patient with liver mets we thought is coming from somewhere else, and ultimately it winded up to be cholangiocarcinoma. And we know about 10 to 15% of patients with cholangiocarcinoma harbor FGFR fusion. So I really think in the future we will kind of have 2.0, 3.0 versions of PGDx. The panel, my understanding from talking to some scientists at Labcorp, they are trying to expand the gene panel. But so far, it's the major advantage is addressing the actionable mutation. I can have a report of 4,000 genes, but if the actionable one are only 1 or 2, the 4,000 are meaningless to me. So what I love about PGDx is that the fact it has the actionable mutations. And hopefully with time we'll add more. I look forward to be part of the clinical studies for MRD testing, high-risk patients, residual disease, using the liquid biopsy as a dynamic molecular monitor for patients during their treatment to see if they're responding. And I think the BR36 data is very intriguing, and I'll keep an eye on the final results.
Yeah, thank you. I mean, I think it's there's certainly a lot of different ways in which we can assess different cell-free DNA features for different applications, and I think minimally invasive therapy selection is really just the starting point for I think a lot of the work to come. Were there any other specific cases you wanted to touch on in terms of how liquid biopsy-based testing has helped to improve your management of care for these patients?
The EGFR patient with lung cancer that I got the results even before the actual tissue biopsy. I thought that was very interesting. The KRAS 12C adenocarcinoma lung that we were able to pick targeted therapy from the get-go. Literally within 2 weeks, the patient was on the drug. And the MSI high.
Okay, great.
So MSI highs, we can use immunotherapy as site agnostic, regardless of the primary.
Yeah, so really a combination of some of the clinically actionable biomarkers that we associate with these tumor types, but also some of the more rare alterations that you maybe only would find through a broader based approach.
Yep. And the other thing, Mark, is when I used other liquid biopsy, I had a lot of insufficient tissue, NOS, in the specimen. With PGDx, I remember only, I think maybe I emailed you or I met someone else about one patient who had insufficient, they could not run the sample. So the I think the panel can be run on a very small circulating tumor DNA sample, and I think that's an advantage even compared to the available, commercially available liquid biopsy panels that are approved.
Yeah, thank you. And then, in terms of turnaround times,
for patients with stage 4 cancer, it's really very crucial to get early diagnosis, early genetic marker identification, and starting treatment. For me personally, as a treating physician, I have few patients where like they have radiologically, for example, cancer consistent with lung cancer, a big lung lesion, multiple metastatic lesions. So I was able to send the test because it was early access, and I got the results even before the actual biopsy. One patient actually had the EGFR mutation, and I was able to tell before even the actual biopsy was done. There's another patient with lung cancer. At the time of progression, I did send PGDx, and the results came back positive for the G12C, and we put her on the sortasertib, the KRAS inhibitor. Also, it has the MSI data, which is we know there is approval for this. For MSI unstable, site agnostic. So wherever the cancer is, if they are MSI high, you can use immunotherapy for those patients. Patient experience has been so pleasant because you can make a decision pretty fast. If you get the results, you can definitely act on it in a timely fashion. You don't have to wait for the NGS. It's really great because the turnaround time is close to 6 days average. I think our site is 6 days. The good thing, I get an email, so it doesn't have to go to the main lab, and then the main lab scan it into Epic system, and then I get the message to my inbox. So the message comes into my email. I open it. There is a link that gives you the report. The report is very concise, very clear, short report, 5 to 7 pages. But as you mentioned, you have the tier 1, tier 2, and tier 3. We base most of our therapeutic decisions based on tier 1, but sometimes you look into tier 2 or tier 3 to consider enrolling the patient in a geocoded clinical trial. Also, the mutations typically are reported with the supporting clinical data or published data. If the patient is interested in a clinical trial, you can always look for the closest clinical trial site that's included in the report.
Yeah, no, I think your feedback throughout that process has been very helpful as we think about continuing to evolve and develop these approaches. So in terms of the clinical report, I think you did a nice job kind of outlining the way that you're managing patients. But any other thoughts in terms of clinical reporting? And what's worked well, or maybe areas that we could continue to think about how to evolve and make that the most appropriate to make decisions for how you manage your patients.
Yeah, I think the looking for other immune markers. If we can include in the report like some immune markers, MSI high is one, and the actionable mutations that the panel has already.
Yeah, thank you. And then we've been talking a lot about your experience, but how has your patient's experience been with the liquid biopsy-based testing?
For oncology patients, time is of an essence. So if you get the results in 5 to 6 days, and instead of waiting for a month or a month and a half, adding to that the insurance approval for the treatment. So it takes sometimes a month and a half to start treatment for patients with stage 4 disease, and that's kind of unacceptable in 2023. So the patients are really very happy. Their families are really satisfied because within a week or 2 weeks, we can make therapeutic decisions, what treatment we're going to use, and we couldn't ask for a better test to be part of the early access program.